My name's Chris Lane, and some of you may actually have met me in one of the cognitive disorders clinics where I work as one of the doctors. And I'm also doing a PhD at the Dementia Research Centre. So I've been asked today to talk a little bit about medication in PCA. And I thought I'd just give you an overview of what I'm hoping to talk about today, and hopefully this does answer some of your questions. I'm going to talk a little bit about the symptomatic treatments that are available in PCA, and these are treatments that help the symptoms of PCA, what those medications are, when we use them, a little bit about how they work, and some of the commonly seen side effects. What I'm also going to do is talk a little bit about future avenues in drug therapy in PCA, and sort of talking a little bit more about some of the disease-modifying treatments that are being developed. And so these are treatments that, rather than purely treating the symptoms, they actually act on the underlying process to try and slow down the disease. And when I give this talk, I'll probably use PCA and Alzheimer's disease interchangeably, because essentially, as I'm sure a lot of you are aware, PCA in the main is a rare form of Alzheimer's disease. And the treatments that we have for PCA are the treatments that we use in all types of Alzheimer's. So, what symptomatic treatments are there? There are two different types of medication available, and some of you may well be on one or another, and some of you may even be on both. There are cholinesterase inhibitors, such as donepezil, galantamine and rivastigmine, and these are the generic names for those drugs. People may be on trade name drugs, so donepezil, for instance, is also known as Aricept. So don't get too worried if you don't see the particular drug you're on. I'm sure you're on one, or you may well be on one of these medications, but just via a different name. And then there's another class of medications called Memantine, which works in a totally different way to the cholinesterase inhibitors. Now, these are treatments that are designed to improve the symptoms of Alzheimer's disease and PCA. Now, unfortunately, these are not a magic bullet. How well they work in people is very variable. For some people, they can provide real benefits, and for other people, the benefits can be much less dramatic. And something that, particularly in the PCA patients talk about is whether they'll be able to see again, because of course visual problems is a prominent feature within PCA. And unfortunately, these medications don't really help to improve vision per se. But what people often describe is that actually it's like a fog has lifted, that there's just a clarity of thought that wasn't there before. And with that, people describe that they have an increase in their confidence and an increase in their energy levels. So it's no small thing, potentially, in terms of how some people notice an improvement. And when do we use these medications? Well, we have guidelines that were released in 2011 by NICE. So NICE is a government organisation. It's the National Institute of Clinical Excellence, which essentially looks at the evidence for medications and determines and provides guidance on when medical professions should be prescribing certain drugs. And what they recommend is that donepezil, galantamine and rivastigmine should be used in mild to moderate Alzheimer's disease. Memantine should be reserved for those people who haven't tolerated one of those cholinesterase inhibitors, and should be used in people with moderate Alzheimer's or severe disease. And the reason being that there wasn't enough evidence to suggest that Memantine is beneficial in mild Alzheimer's. And NICE specifically looked at whether people should be on combination treatment with Memantine and a cholinesterase inhibitor. And at the time, they looked at all the studies comparing single drug treatment with using both, and they declared that there wasn't enough evidence to suggest that there was a benefit from using both together. There has, however, been a recent European guideline So this is separate from NICE. It's essentially a European Confederation of Neurologists who have looked at all the up-to-date information on combination therapy with cholinesterase inhibitors and Memantine. And they found some weak evidence, so bear in mind it's weak evidence, it's not stonking stuff, but it's weak evidence that there may be some mildly beneficial effects of using dual therapy in people with moderate to severe Alzheimer's disease. So it's more of a suggestion of a benefit rather than a frank, this is a wonder combination. And actually it's certainly something that at Queen Square we're considering when we see people in clinic. But of course everyone in terms of their local guidelines for prescription may be different. And not everyone is aware necessarily of these guidelines. And of course these guidelines aren't binding in any way, unlike the NICE guidelines. So I'm going to talk a little bit about cholinesterase inhibitors and how they work. And I don't want people to get too bogged down in this diagram. This is really for people who are particularly scientifically minded, who might want to look through the process. So I'll try and give a sort of a simplified overview of how cholinesterase inhibitors work. So if we think about the brain and how the brain works, and essentially nerves communicate with other nerves. And the way that they do that is through releasing chemical messengers between nerve cells, or neurotransmitters. And in Alzheimer's disease, what happens is some of those chemical messengers drop down to low levels. Others of those chemical messengers actually increase inappropriately. And there's one particular chemical messenger called acetylcholine, which drops down to low levels in people with Alzheimer's disease, with PCA, compared with people who don't have any cognitive problems. And so what these medications work to do is to boost those levels of that chemical messenger, that acetylcholine, in the brain to improve the signalling between nerve cells. And the hope is that by improving that signalling, that actually can result in some improvements in people's thinking. Now, like all medications, there are potential side effects. But actually, in the main, these medications are quite well tolerated. One way that we try and work to reduce the likelihood of people developing side effects is that we start people on the lowest dose possible and we build people up gradually. And of course we've got people like Mandy who are great because people are seen in Mandy's clinic and they're started on the medication, and she's a great port of call if there are any problems. And she'll keep a close eye on things to see how people are getting on. Some of the common side effects that have been reported and things that we warn people about, particularly are tummy upsets, so feeling a bit sick. Some people might vomit, and some people can get loose stools and diarrhea with it. Now, this often happens when we start people on the treatment, and sometimes these actually get better with time. So if the symptoms are mild, often we see how people go because they can get better. But sometimes they don't, and we can switch the medications and see if another one treats people a bit better. We also, because of this side effect, tend to start people on the medication at night. And that's because nausea is one of the major complaints. And actually, if we give people the medication at night, people often sleep through the night and sort of sleep through the worst of that nausea. Some people report muscle cramps. Some people feel a bit more tired on the medication. Some people actually have difficulty sleeping. And some people actually describe very vivid dreams. Now, for some people, actually, the vivid dreams are perfectly pleasant and aren't a problem. For other people, they're not so much fun. And actually, because we tend to start the medication at night because of this first side effect, actually what we can do is switch the medication to the morning. And often, actually, those side effects get a bit better. Some people might get a slow heart rate. And that's why, when we start people on this medication, we always check their pulse before they start. And if the pulse rate is a bit on the slow side, what we might do is do a tracing of the heart, just to see that there isn't any reason why people can't go onto the medication. And finally, a final note, it doesn't seem to be reported in the literature particularly, but anecdotally we have a lot of people who start these medications and say that they get a runny nose. And actually, it sort of makes sense in terms of the way that it works, and we see that quite a lot. So that is one of the side effects we see. So I'm going to talk a little bit now about Memantine, and this is this other medication that works in a different way to the cholinesterase inhibitors. And again, there's this diagram up for the scientifically minded amongst you, but don't worry too much about it. So essentially, when I said that in Alzheimer's disease and PCA, some of those chemical messengers drop, like the acetylcholine, but other of those messengers, chemical messengers, actually inappropriately elevate their levels. And one of those neurotransmitters or chemical messengers that gets to inappropriately high levels is one called glutamate. And what happens is when glutamate's at a very high level, that can actually be toxic to nerve cells and cause them to malfunction. And in addition, if you think about it, if you have a lot of this chemical messenger flying between nerve cells who are trying to send signals across, actually those signals get a lot of static around them. So actually the signal that's trying to be passed on isn't very clear because of all this static around it. So what the memantine does is it acts to block the effect of glutamate. And by blocking that effect, the aim is that it blocks some of that damaging effect that it has on the nerve cells, and it also reduces that static down. So it actually, hopefully, makes a clearer signal, allows for clearer communication between nerve cells. And again, the idea is that boosts people's thinking. Again, like all medications, there are some side effects. But in the main, actually, Memantine is very well tolerated, and most people don't seem to report much in the way of problems. Like the cholinesterase inhibitors, we always start on a low dose and build up gradually. But some people will complain of constipation. Some people might get a bit sleepy. Other people might report headaches or dizziness. But really, in the main, these medications are well tolerated, and people don't have too much in the way of side effects. And so that sort of covers the symptomatic treatments that we have in Alzheimer's disease in general and PCA. And as you can see, whilst they can provide some help, they are not wonder drugs, unfortunately. So there's still an awful lot of work, obviously, that's going on in drug development. And in terms of drug development, there are still lots of drug trials companies looking at developing treatments, symptomatic treatments, so that can help boost thinking more effectively than the ones we already have. But a lot of focus is now on trying to slow down the underlying process that's going on in PCA and in Alzheimer's disease more generally. So I'm going to talk a little bit about that now. And again, hopefully it's not too technical, but of course we'll have questions at the end, and if you've got any questions, please, at the end, feel free to ask. So in order to understand what these disease-modifying treatments are hoping to do, or what they're aiming to do, you have to understand a little bit about what happens in Alzheimer's disease in general. And so what I'm going to talk about is just the process that we think is going on in Alzheimer's disease, and there's still a lot of unanswered questions, but this is one hypothesis, this is one theory as to what's going on. So essentially, everyone has a protein called amyloid in their brain, and some of you may well have heard of this because it's in the news quite a lot. And this amyloid protein, so everyone has it, it's produced in the brain, it gets removed from the brain, so there's a constant cycling of this amyloid protein going on. And everyone gets a little bit more as they get older. For some reason, people who go on to develop Alzheimer's, PCA, they accumulate a lot more of this amyloid protein. So they develop very high levels of this amyloid in the brain. And when the amyloid gets to high levels, it becomes toxic to nerve cells. And so nerve cells begin to malfunction, and then nerve cells are lost. And actually, we think that this amyloid cascade, this amyloid problem is actually developing up to 15 years before symptoms actually develop. And over time, nerves malfunction, they're lost, and then eventually we see shrinkage on scan. So that's just showing on the graph. There are these various curves with time lags between them, because essentially there's a long period of time between each thing. So there's shrinkage within the brain, and eventually symptoms develop. So one strategy that's being used is to try and remove amyloid protein from the brain. And one way of doing that is to use antibodies. So antibodies are substances produced by the human body to fight infection, and they tend to bind to bugs like bacteria and viruses and flag them up as bad things that need to be removed from the body. But what we can do is we can make antibodies in the laboratory that bind to amyloid protein. And what we then do, or what the treatment trials are doing, is they're giving people who have Alzheimer's disease, giving them these antibodies either via a drip in the arm or an injection under the skin. And these antibodies bind to amyloid in the brain. And the idea is that they will then trigger the removal of the amyloid protein from the brain. Now, there have been quite a lot of studies in this field. And some of you may well be aware that actually a lot of these studies haven't shown benefits. And the feeling is that a lot of those studies were done in people who had quite severe disease. And actually, some of them showed that some of the amyloid was actually being removed from the brain, but it appeared that actually it was a bit too late to be giving these treatments. Too much damage had been done, unfortunately. And so there is now a shift to treating people earlier when they have milder symptoms. And some of you may well have heard in the news, because there was quite a lot of press about it in the summer, about several antibody studies that have shown in the mildest cases some suggestion of a slowing of the progression of the Alzheimer's. Now, it's important to bear in mind, don't believe all the hype. The press really sort of builds it up, and Daily Mail's cured Alzheimer's every other day, but so just bear in mind that actually take it all with a pinch of salt, what you read in the news. But it's a start, actually, because up until now we really, we haven't had any favourable results at all, and I think there's still an awful lot of work that needs to be done. But it does suggest certainly that the amyloid protein is something that we should be targeting, because there's been a lot of debate over whether we should be focusing on that protein or other proteins that are affected in Alzheimer's disease. And going back to sort of talking about the amyloid, we think this is important, and of course a lot of you may well have had a lumbar puncture, and that's one of the proteins that we look for when we do that lumbar puncture. We're looking for that amyloid protein in the spinal fluid, and we're looking for the changes that happen in Alzheimer's disease. But anyway, so there have been a number of studies two studies which have had promising findings, but still a lot of work to be done. And these are just naming solanezumab and aducanumab are the two drugs. If they end in a mab, as a rule of thumb, that means that they're an antibody. But they're totally unpronounceable in the main. So I've done a lot of work in trials, so I've said these drugs a lot of times, but they are real tongue twisters. So in terms of other targets, amyloid isn't the only target, or rather amyloid removal isn't the only target of drug treatment. So some people are focused on actually blocking the production of amyloid in the brain. And the benefit of some of these medications are that the ones that have been developed, and some of them are possibly going into trials, are tablets. So part of the problem with those antibodies is that they have to be given through an injection, either in the arm or under the skin. So they are not terribly convenient necessarily to people. So obviously tablet forms are always a good option. Some people are focused on other proteins that accumulate to high and toxic levels in Alzheimer's, and one of those is tau. So there is work on focusing on tau and trying to remove tau from the brain. And then there's also work looking at anti-inflammatory agents, because there is a suggestion that actually there's inappropriate inflammation going on in the brain in Alzheimer's at very low levels, but perhaps actually targeting this may be another beneficial approach. And in reality, it may well be down the line, we're talking a long time down the line, but there may be people who end up on lots of different treatments, targeting lots of different aspects of the underlying disease process. But unfortunately, at the moment, we're a long way away from that. Now, just to say, I've talked about treatment trials in Alzheimer's disease. Obviously, PCA is a subgroup within Alzheimer's disease. Some of these studies don't include people with PCA because they look at typical, what we call typical or memory-led Alzheimer's. But there are studies actually that include people with posterior cortical atrophy, because the most important thing is demonstrating that a person has amyloid in their brain. And especially if you're looking at removing amyloid from the brain, whether it's PCA or amnestic Alzheimer's, then you can be looking for that amyloid removal effect. So there are treatment trials out there, not just for typical Alzheimer's disease. And I think I'm going to leave it there. And if anyone has any questions, I hope I haven't bamboozled people. If you want to ask me questions, or Mandy, then please feel free.
Chris, thank you so much. I'm Seb Crutch. I'm one of the psychologists here, and my job here is to be the microphone that we don't have. So if you have questions, I will try and repeat them through the microphone so everyone else can hear them, and then Chris is going to try and answer them for you. So fire away. So the question is, what are the tau deposits?
Okay, so it's a complicated one. I tried to sort of... So essentially, we know that amyloid accumulates, and that clumps together, and we think that the clumps themselves may be toxic, but also various types of amyloid in high levels are toxic, essentially. And what then happens, that certainly appears to be the earliest stage, but then we see clumps of other proteins developing, and those clumps are of tau protein. So again, tau is a protein that is normally produced in the brain, and it has an important role in health. But when it accumulates and it clumps together, it can also become toxic. And there's a lot of debate, is that tau clumping together because nerve cells are being lost, and that's just a bystander effect of the nerve cells being lost and malfunctioning, or is that tau actually a really critical, that clumping together of tau a really critical hit in Alzheimer's, and is that actually a very important toxic pathway?
So the importance of regular tablet taking?
Well, I mean, they should be taken ideally every day, of course, just because in order to try and keep the levels of the drug in the bloodstream at a reasonably stable level. I think as to the timing during the day, I wouldn't have said that a few hours causes a problem. I think it's a difficult one to say. I mean, you have to work with in the circumstances that you're in, and of course, if that's how it works, then I think that's fine. I think that's fine as long as someone's having it every day. That's ideal. You ideally don't want to be missing doses, but again, if the occasional dose gets missed, again, not ideal, but it's not the end of the world. So. Okay, so that was just to say that if people don't like taking tablets, there are sometimes oral dispersible forms, so basically dissolvable forms of the tablet. And as this gentleman was saying, actually, they are more expensive, and so sometimes it's more difficult to get them because doctors aren't so keen to prescribe the more expensive form. But so that's one option if people don't like tablets. Another, depending on the type of tablet, some of them you can actually crush up, and you can then put that into a yogurt, say. And so if the person is keen on having yogurts, then you can sort of slip it under the radar a little bit. And of course, if tablets are a real problem, then there are patches potentially for people.
I was just going to say that you need to get some advice from a pharmacist before
yes,
crushing
absolutely.
tablets,
yeah.
Because some tablets don't suit being crushed.
Yeah, quite right.
And if you're covertly giving it to somebody, then you run into a bit of a capacity issue. So, people have to be, happy to take it in a crushed form and in agreement for you to kind of slip it, you know. I think we've gone up past the days of slipping it in people's tea.
Quite right.
Yeah.
Okay.
Just be cautious. That's
Yeah.
Other questions?
Well, I think there's another.
So do the benefits diminish over time?
I think you've sort of answered the question, actually. I mean, no, but you have, no, because because for each person, we just don't know. And of course, if people are tolerating the medication and they're not getting side effects, of course, over time, unfortunately, things will decline. And the drugs can't stop that. And so what we certainly, if people are not having a problem, then we tend to carry them on. It's only if there are real difficulties arising that we may consider stopping them.
So what can one do about the tiredness if that's the side effect that you have?
And do you think that, has that got worse on the donepezil? It can be very difficult to judge because, of course, tiredness is a key symptom, actually. And so it can be difficult to unpick what is the underlying disease, progressing and what is actually a side effect. I mean, obviously, if there has been a clear relationship between the two, I mean, it's something to perhaps have a chat with Mandy about and sort of, we'll take it sort of away from the meeting and sort of see whether something else can be looked at. But there aren't, unfortunately for the tiredness in general, there aren't any sort of symptomatic treatments for that specifically. But have a chat with Mandy, I think, is...
So the comment, for those of you who might not have been able to hear, is of someone who seemed to tolerate Aricept very well for 6 years, then developed some difficulties which resolved once the treatment was stopped, and actually has responded well to Memantine. I don't know if you have anything in comment, Chris.
Well, I think the only thing to say, I mean, when you think about what these medications are doing, they are influencing the levels of neurotransmitters in the brain. And you don't just have two, you don't just have this glutamate and this acetylcholine, you've got lots and lots of different ones. And actually, they're all in a fine balance, essentially. And who's to say? I mean, I don't know, but one would guess that perhaps it's because of an imbalance which wasn't present 6 years earlier, but 6 years on, perhaps for whatever reason, that imbalance in the chemical transmitters predisposed to a depressive state. I don't know. I mean, that's me just sort of guessing on the spot. I hope it's a scientifically based guess, but it's difficult to say. But the key is to bear these things in mind and always keep an open mind. Just because you're on a medication doesn't mean that you need to be on it in perpetuity. Yeah, can't say
perpetuity.
Thank you.
Yeah. So the comment is that for a variety of reasons, the effect may vary over time. But I think also the comment you made, Simon, about inadvertently stopping, and I think quite a few people might have had this for various reasons, might have had a few days where a couple of doses are missed, and actually there is a sense, it's sort of an inadvertent test of whether it's still beneficial, is that actually things do seem harder during that period when, for some people who have a response to these medications, when that the tablets aren't taken. Chris, without wishing to throw you too much of a curveball, I wondered if you could just comment, the guidance, as you showed from NICE, is not to give, for example, the combination of Aricept and Memantine, but of course we've heard already from a couple of people in the room that they are being prescribed either from a single physician or via a private prescription for the second medication, and so some people are clearly out there trying the combination, and whether there's any research that means that guidance you think might potentially change in the future, or at least whether the issue is still being looked at.
Well, there is the recent European guidance that came out, which suggested that there may be a very mild benefit in co-prescribing Memantine and cholinesterase inhibitors. So there is, I mean, but it's not strong evidence, and I don't think, unfortunately, I suspect there aren't going to be a lot more studies into it, but there is a trend towards benefit. I think a key thing about the NICE 2011 guidance, cost is also an issue. And of course, medications are becoming cheaper because they come off license. So you can buy the generic, or the NHS can buy generic forms of the drug. So rather than Aricept, you can get donepezil. And actually, that may well sway things in the next NICE guidelines. I don't know. But certainly we consider co-prescription, and we will ask local GPs to consider it. but they have their own sort of guidance. Really.
So if I were in this situation, I just suppose I'd draw from that perhaps that although it's good if you're with someone who will consider co-prescription, the evidence that's available is that the benefit is modest. So
exactly.
it's not going to be I think that's unlikely
key.
To be a night and day difference.
No.
If it's causing you anxiety that you're with a physician and you are for whatever reason only on one medication.
Yes, I think that's a key take-home message. Just because it may have it's a very moderate, very modest benefit, if at all. So don't panic if you're only on one medication.
Thank you. So the question really is, are all the other symptoms like difficulty with reading and putting numbers in a sequence and adding up and so forth, is that to do with the back of the brain? So it's a perfectly reasonable general question about PCA for people who haven't been before.
Yeah, absolutely. So when you're absolutely right. Essentially, posterior cortical atrophy, what that is describing is that the areas that are affected by the Alzheimer's is the back of the brain. So the areas of the brain that are involved in visual processing, that are involved in calculation, in spelling, in coordinating complicated movements. So, and that's a key thing that we don't understand, is why some people who have this amyloid protein in the brain go on and develop the typical memory-led classic Alzheimer's, whereas other people will have this same amyloid and it doesn't seem to be affecting other areas. It's the same sort of distribution in the brain, but it affects the back of the brain.
So the question is, can you essentially rebuild the back of the brain so that we can resolve these symptoms by making structural change to the back of the brain rather than just a chemical change?
So what you're talking about there is, rather than halting neurodegeneration, actual regeneration.
Right.
And people are thinking about things like that, but we are a very long way away from any sort of therapies that can regenerate. I think, to be honest, I think the main focus at the moment is trying to halt it in its tracks. That is a complicated task as is. The fact is, if you think about it, we can't grow back someone's arm. Which is, relatively speaking, a far more straightforward structure actually than the human brain when you think about all of the the synapses, those connections, billions upon billions of connections within the brain. So regeneration in general is, I think the golden, that is a sort of a golden aim for all of medicine, but we're very far away from that, very far away.
Just one brief comment I'd make linking the symptoms that you were mentioning, which relate to the back of the brain, and the medication, is that the nature of the side effect Chris mentioned about having vivid dreams could well be connected, that these drugs are essentially improving the messages between damaged sets of cells. And so the prominent visual dreams or colourful dreams that a lot of people describe could be highlighting the fact that the messages are getting through in this damaged visual part of the brain at the back. So just one comment.
So this gentleman was talking about his wife who recently developed quite acute onset tiredness, was walking shorter distances and eventually couldn't really walk at all, and it turned out that she had multiple blood clots in her lungs and is now on a blood thinning agent. So the question is really whether, I think the question is a question of could they be linked? Yeah, I'm not aware of a connection between or a link between memantine increasing the risk of developing blood clots. It's very important if people do develop tiredness, and particularly if it's very acute onset, the number of causes of tiredness are huge, actually, really, really huge. So you must always go and see your doctor and just make sure that nothing else is going on, because someone could be mildly anemic for whatever reason, or their blood pressure may be a bit low because their blood pressure tablets are a bit too much, or there are so many different things that could be causing it. I mean, I don't think the memantine, I don't believe there's a link between memantine and causing blood clots, but you're right, but you must always be aware that if there is a dramatic change, don't just attribute it to the medication. It's always worthwhile getting seen by a doctor.
So how do you find out about forthcoming trials?
So it's a very good question. Actually, I don't know if people use alzforum.org I've actually put the link at the bottom, alzforum.org. It's quite a useful one for just sort of giving updates on research that's being done and trials that have announced results, and actually it's quite sort of user friendly for the public, and I think it's quite a useful resource. If you are interested in clinical trials, it's worthwhile. There's a thing called clinical trials. I think it's .gov. I'd have to double check. Don't quote me on that. There are websites that essentially are meant to list all of the clinical trials that are going on. I had a quick look at one of them a couple of days ago, and actually I don't think it's kept terribly up to date. So if you're seen at Queen Square, then you can talk to us. Certainly clinical trials are being run through the Dementia Research Centre. You can have a look on the Dementia Research Centre website, which would certainly give you an idea of trials that are going on in London. And it's always worthwhile, perhaps, you can always call up one of our trials nurses who can perhaps point you in the right direction if you're not local.
Chris, thank you very much again.